Nursing 345, ears and eyes, and nose, mouth, and throat. This slide has the objectives for this week, which include comprehend the significant differences between the skin of the very young and the older adult and the healthy adult. Describe the differentiation between normal and abnormal skin color for various ethnic groups. Identify the structures and landmarks of the neck. Describe the assessment that would follow the palpation of an abnormal lymph node. Identify the structures viewed through the ophthalmoscope. Discuss the three most common causes of decreased visual functioning in the older adult. State the functions of the inner ear that can be assessed. Incorporate health promotion concepts when performing an assessment of the ears. Acknowledge the effects of some of the age-related changes that take place in the mouth, and assess health promotion concepts when performing an assessment of the nose, mouth, and throat. The ear is the sensory organ for hearing, and it also helps to maintain equilibrium. It has three parts, the external, the middle, and the inner ear. The shape of the external ear funnels sound waves into its opening, the external auditory canal. The translucent pearly gray tympanic membrane, or eardrum, separates the external and middle ear. Otoscopic inspection of this membrane reveals several features. A prominent cone of light is visible. The malleus pulls at the center of the ear, causing it to appear oval and slightly concave. The umbo, the manubrium, and the short process are parts of the malleus that show through the translucent drum. The middle ear is a small air-filled cavity inside the temporal bone. It contains tiny ear bones, the malleus, incus, and stapes. The middle ear has three functions. The first function is it conducts sound vibrations from the outer ear to the central hearing apparatus in the inner ear. It protects the inner ear by reducing the amplitude of loud sounds. Its eustachian tube allows equalization of air pressure on each side of the tympanic membrane. The inner ear contains the bony labyrinth, which holds the sensory organs for equilibrium and hearing. In the labyrinth, the vestibule and the semicircular canals compose the vestibular apparatus, and the cochlea contains the central hearing apparatus. Although the inner ear is not accessible to direct examination, you can assess its function. Hearing involves the auditory system at peripheral level, brainstem, and cerebral cortex. The ear transmits sound and converts its vibrations into electrical impulses, which the brain analyzes. Anything that obstructs sound transmission impairs hearing. Hearing loss may be conductive, sensory neural, or mixed. So as I said, hearing loss is anything that obstructs transmission of sound and impairs hearing. You can have conductive hearing loss, which is a partial hearing loss. It involves the mechanical dysfunction of the external or middle ear. Cerumen buildup, otosclerosis, and ototoxicity are examples of what may cause conductive hearing loss. Sensory neural or perceptive hearing loss indicates a pathological condition of the inner ear, cranial nerve 8, or the auditory areas of the cerebral cortex. Presbycusis, an age-related gradual degeneration of the nerve, and ototoxic drugs, which affect the ear cells in the cochlea, may be the cause. Mixed hearing loss results from conductive and sensory neural causes. At different developmental stages, there may be anatomic differences that alter hearing. In infants, the eustachian tube is relatively short and wide and is more horizontal than it is in adults. This allows for easier migration of pathogens to the middle ear from the nasopharynx. Also, the lumen is easily occluded. In adults younger than age 40, otosclerosis is a common cause of conductive hearing loss. In aging adults, hearing acuity may be decreased because of the coarse and stiff cilia lining the ear, impacted cerumen, and nerve degeneration in the inner ear. Genetic and cultural variations related to the ear affect the incidence of inner ear disorders. Otitis media or middle ear infection occurs as a result of obstruction of the eustachian tube or passage of nasopharyngeal secretions into the middle ear. One of the most significant risk factors predisposing infants to acute otitis media is secondhand smoke. Genetic variations of the type of cerumen are tied to chromosome 16. So, dry cerumen is gray, flaky, and frequently forms thin mass in ear canal. Wet cerumen is honey brown to dark brown and moist. To obtain subjective data, you need to ask questions to investigate earaches and ear infection, discharge from ears, hearing loss, environmental noise, tinnitus, and vertigo, and cleaning of the ears. During history, notice clues from normal conversation indicating possible hearing loss. They may include lip reading or watching your face and lips rather than your eyes, frowning or straining forward to hear, posturing of the head to catch sounds with better ear, misunderstands questions, frequently asks you to repeat. The person may become irritable or show startle reflex when you raise your voice. Person's speech sounds garbled, vowel sounds are distorted. They may have an inappropriately loud voice, or they may have a flat, monotonous tone of voice. Flat, monotonous tone of voice. Equipment needed includes an otoscope with a bright light, fresh batteries, give off white, not yellow light. Pneumatic bulb attachments, sometimes used with an infant or a young child, and tuning forks. To obtain objective data, first inspect and palpate the external ear. Note the size and shape of the auricle, ear position, and alignment on the head. Observe the skin condition, including color and lumps or lesions. Check for tenderness. Evaluate the external auditory meatus, noting its size and any swelling, redness, discharge, cerumen, lesions, or foreign bodies. Next, perform an otoscope exam. Note the size of the auditory meatus. With the otoscope, inspect the color, characteristics, and integrity of the tympanic membrane. Note its position, which may be flat, bulging, or retracted. Then test hearing acuity. First, note the patient's behavior response to conversational speech. If needed, perform the whispered voice test or the tuning fork test or both to measure conduction. To assess the vestibular apparatus, perform the Romberg test, which evaluates standing balance. Based on a patient's developmental stage, adjust your assessment technique or expected findings. For example, for a child, use different tests to assess hearing acuity. In an older adult, expect the tympanic membrane to appear whiter, more opaque, and duller than in a younger adult. For infants, all states have established early hearing detection and intervention programs, so all infants should be tested for risk of hearing loss before they are discharged from the hospital. During the ear assessment, incorporate health promotion. For instance, teach young people about the risk of hearing loss with digital music players and earbuds, and suggest ways to prevent hearing loss from overuse of these devices. This next slide is an example of subjective charting, and it states hearing is good, no earaches, infections, discharge, hearing loss, tinnitus, or vertigo. And your objective note, pinna, skin intact with no masses, lesions, tenderness, or discharge. Otoscope, external canals are clear with no redness, swelling, lesions, foreign body, or discharge. Both tympanic membranes are pearly gray with light reflex and landmarks intact. No perforations. Hearing, whispered words heard bilateral. Weber test, tone heard midline without lateralization. Rhine test, AC is greater than BC and bilateral. Next, we will talk about the eye. The eye carries visual data that are crucial for survival, education, and pleasure. More than half of the neocortex is involved with processing visual information. The external anatomy of the eye includes many structures. Each eye is protected by a bony orbital cavity surrounded with a cushion of fat. The eyelids further protect the eye from injury, strong light, and dust. The upper eyelid is larger and more mobile. Eyelashes curve outward from the lid margin to filter out dust and dirt. When closed, the lid margins approximate completely. The canthus is the corner of the eye where the lids meet. The conjunctiva is a thin mucous membrane. It's transparent protective covering of the exposed part of the eye. The lacrimal apparatus provides constant irrigation. There are six muscles that attach the eyeball to its orbit and serve to direct the eyes to points of interest. The superior, inferior, lateral, and medial rectus muscles, and the superior and inferior oblique muscles. The movements of the extraocular muscles are stimulated by cranial nerves 3, 4, and 6. The internal anatomy of the eye includes many structures. The eye has three concentric coats or layers. The outer layer is the sclera, a tough, fibrous, protective white covering that is continuously anteriorly with a smooth, transparent cornea. The cornea, which is the part of the refracting media of the eye, covers the iris and the pupil. The middle layer is the choroid, which has dark pigmentation to prevent light from reflecting internally and is heavily vascularized to deliver blood to the retina. The choroid is continuous with the ciliary body and the iris. The ciliary body controls the thickness of the lens. The iris serves as a diaphragm, bearing the opening at its center. Its muscle fibers contract and dilate the pupil, controlling how much light enters the retina. The inner layer is the retina, which is the visual receptive layer of the eye. In the retina, light waves are changed into nerve impulses. The area of the sharpest and keenest vision is the fovea centralis. The macula, a slightly darker pigmented region surrounding this area, transfers light from the center of the visual field. Visual reflexes include the pupillary light reflex, fixation, and accommodation. The pupillary light reflex is the normal construction of the pupils when bright light shines on the retina. Fixation is a reflex direction of the eye toward an object attracting a person's attention. Accommodation is the adjustment of the eye for near vision. It is accomplished by ciliary muscle movement. The eyes undergo age-related changes. At birth, eye function is limited. Peripheral vision is intact in newborns, however. The macula is present at birth, but it matures by the age of 8 months. Eye movement is poorly coordinated, but matures by age 3 to 4 months. The eyeball reaches adult size by the age of 8 years of age. With aging, lacrimal gland involution causes decreased tear production and dry, burning eyes. Pupil size decreases and the lens loses elasticity, causing presbyopia. The transparent fibers of the lenses begin to thicken and yellow, resulting in senile cataract. Visual acuity may diminish gradually after age 50. In older adults, the four most common causes of decreased visual functioning are cataracts, glaucoma, age-related macular degeneration, and diabetic retinopathy. Culturally based variability exists in the color of the iris and retinal pigmentation, with darker irises having darker retinas behind them. Visual impairment is not being able to see letters on the line 20/50 or below on the eye chart. Racial disparities exist among major eye diseases and in visual impairment. To obtain subject data, you need to ask questions again to investigate the following topic: vision difficulty, including decreased acuity, blurring, and blind spots; eye pain, burning or itching; diplopia; strabismus, redness or swelling; watery or discharge from eyes; history of ocular problems; glaucoma; use of glasses or contact lenses; patient-centered care; medication, systemic or topical; and vision loss. Also, additional history for infants and children should include vaginal infections in the mother at the time of delivery, developmental milestones of vision noted by the parent, routine vision testing at school, and awareness of safety measures to protect the child's eye from trauma. Aging adults should be asked about visual difficulty with driving or difficulty with night vision. Glaucoma testing, history of cataracts, dry or burning eyes, and decrease in usual activities related to vision um, problems. And you may also want to find out if they have any history of eye surgery when you're collecting subjective data. To obtain objective data, the first test the central visual acuity with a Snellen or other eye chart. For patients older than 40 or who have difficulty reading, you also need to perform the test for near vision. Next, assess visual fields for loss of peripheral vision using the confrontation test. Continue by observing extraocular muscle function. To do this, assess the corneal light reflex using the Hirschsprung test. Also perform the cover test and the diagnostic position test, which is known as the 6 cardinal positions of gaze. Then inspect external eye structures. After a general inspection, specifically assess the eyebrows, eyelids, and lashes, eyeball alignment, the conjunctivae, and the sclera, upper lid eversion, and lacrimal apparatus. Inspect anterior eyeball structures, observe the cornea and lens. Also assess the iris and pupil, particularly noting their size, shape, and quality, the pupillary light reflex, and accommodation. Finally, inspect the ocular fundus or the internal surface of the retina using an ophthalmoscope. And here's your checklist. So to test visual acuity, you would use the Snellen eye chart. Test visual fields, confrontation test, inspect EOM function. You would do the corneal light reflex, cover test, and diagnostic positions test. You would also inspect external eye structures, inspect anterior eyeball structures, and inspect ocular fundus. This next slide is a note and a sample note, and it's vision reported good with no recent change. No eye pain, no inflammation, no discharge, no lesions. Wears corrective lenses. Vision last tested 1 year prior to assessment. Test for glaucoma at the time was normal. So that was for subjective data. The next is a note for objective data. Snellen chart, OD is 2020, OS 2020, fields normal by confrontation, corneal light reflex symmetric bilaterally, diagnostic position test shows EOMs intact, brows and lashes present, no ptosis, conjunctiva clear, sclera white, no lesions, perla, pupils equal, round, reactive to light. Fundi, red reflex, present bilaterally, discs flat with sharp margins, vessels present in all quadrants without crossing defects. Retinal background has even color with no hemorrhages or exudates. Macula has even color. Next, we will talk about the nose, mouth, and throat. The nose is the first segment of the respiratory system. It warms, moistens, and filters inhaled air and is a sensory organ of smell. It's innervated by cranial nerve 1. Externally, the nose is shaped like a triangle. It consists of a bridge, a tip, and 2 nares. Internally, the nasal cavity extends back over the roof of the mouth. Nasal hairs and ciliated mucous membranes filter dust and bacteria. The nasal mucosa has a rich blood supply which warms inhaled air. The septum divides the nasal cavity into 2 air passages. The anterior septum holds Kisselbach's plexus, the most common site of nosebleeds. The turbinates are bony projections that help warm, humidify, and filter the inhaled air. The sinuses drain into the middle meatus, and the nasolacrimal ducts drain into the inferior meatus. The paranasal sinuses are air-filled pockets in the cranium. They lighten the weight of the skull, serve as sound resonators, and provide mucus. The mouth is the first segment of the digestive system and an airway for the respiratory system. It also contains taste buds and aids in speech production. The oral cavity is a short passage bordered by the lips, hard palate and soft palate, cheeks, and tongue. The mouth includes the tongue, 32 teeth, gums, uvula, and openings for 3 pairs of salivary glands. The glands secrete saliva, a clear fluid that moistens and lubricates the food bolus and starts digestion and cleans and protects the mucosa. The throat is the area behind the mouth and nose. The oropharynx is separated from the mouth by folds of tissues on each side, which are anterior tonsillar pillars. Behind these folds are tonsils, masses which are masses of lymphoid tissue. The nasopharynx is continuous with the oropharynx and contains the pharyngeal tonsils, or adenoids, and the eustachian tube openings. The nose, mouth, and throat undergo certain developmental changes. By age 2, children normally have 20 deciduous teeth. These teeth are lost between ages 6 and 12 and are replaced by permanent teeth. In pregnant women, nasal stuffiness and epistaxis may occur as a result of increased vascularity in the upper respiratory tract, and the gums may be softened. In aging adults, loss of subcutaneous fat may make the nose appear more prominent. Older adults may experience a decreased sense of smell and taste, as well as tooth loss, which can contribute to nutritional deficits. To obtain subjective data about the nose, the clinician should ask about discharge and frequency of colds, sinus, pain, trauma, nosebleeds, allergies, and an altered sense of smell. Questions about the mouth and throat: you should investigate sores or lesions, bleeding gums, toothaches, hoarseness, dysphagia, altered taste, smoking and alcohol consumption, and dental care. To obtain objective data, begin by inspecting the external nose. Observe for symmetry, deformity, inflammation, or lesions. Test the patency of each nostril to reveal any obstruction. Inspect the nasal cavity with the nasal speculum, noting the color and integrity of the nasal mucosa, and check the septum for deviation, perforation, or bleeding. Also observe the turbinates to check their color and detect exudate, swelling, or polyps. Complete the assessment by palpating the frontal and maxillary sinus areas, identifying any areas of tenderness. Next, turn your attention to the mouth. Using a tongue blade and pen light, inspect the lips, teeth, gums, tongue, and buccal mucosa. Inspect the palate and uvula. Also check their integrity and mobility as the patient says, ah. This action also tests one function of cranial nerve 10. Finally, assess the throat. To do this, inspect and grade the tonsils and inspect the pharyngeal wall, noting its color and exudates or lesions. Test cranial nerve 12 by having the patient stick out their tongue. If indicated, also assess the gag reflex, which tests cranial nerve 9 and 10. Perform developmentally appropriate assessments. For example, in a neonate, palpate to assess the integrity of the palate as well as the sucking reflex. So your checklist list for your nose is inspect external nose for symmetry, any deformity or lesions, palpation to test for patency of each nostril, inspect with nasal speculum the nasal mucosa, septum, and turbinates, palpate the sinus area. Mouth and throat, you need to inspect with pen light, mouth, teeth, gums, buccal mucosa, palate and tonsils, and pharyngeal wall. Palpate when indicated. Don't forget to incorporate health promotion in your assessment of the nose, mouth, and throat. For instance, if the patient uses smokeless tobacco, explain that these products increase the risk of oral cancer. Review the early signs of oral cancer with the patient and discuss other effects of smokeless tobacco. Emphasize that smokeless tobacco use is not a healthy alternative to smoking. So here is our sample charting for subjective data. Nose, no history of discharge, sinus problems, obstruction, epistaxis, or allergy. Colds, 1 to 2 a year, mild. Fractured nose during high school sports, treated by MD. Mouth and throat, no pain, lesions, bleeding gums, toothache, dysphagia, or hoarseness. Occasional sore throat with colds. Tonsillectomy at age 8. Smoked cigarettes Smokes cigarettes 1 pack per day times 9 years. Alcohol socially about 2 times a month. Visits dentist annually. Dental hygienist 2 times a year. Flosses daily. No dental appliance. Oh, I'm sorry, this is the same. Oh, here's the nose. Did we do that? Oh, this is the objective. I'm sorry. So for your objective nose, the nose is symmetric, no deformity or skin lesions. Nares patent, mucosa is pink, no discharge, lesions or polyps, no septal deviation or perforation. Sinuses, no tenderness to palpation. Mouth, patient can clench teeth. Mucosa and gingiva, pink, no masses or lesions. Teeth are all present, straight, and in good repair. Tongue smooth, pink, no lesions. Protrudes in midline, no tremor. Throat, mucosa pink, no lesions or exudate. Uvula rises in midline on phonation. Tonsils out, gag reflex present.